Hello and welcome. On behalf of CME Outfitters, thank you for joining us for today's CMEO briefcase titled Applying Patient-Centered Pain Care to Practice, a case of chronic pain and opioid use disorder. Today's program is supported by an independent educational grant from opioid analgesic REMS program companies. I am Melissa Weimer. I'm an associate professor of medicine and public health at Yale School of Medicine and School of Public Health. I'm also the medical director of the Addiction Medicine Consult Service at Yale New Haven Hospital. I'll be today's moderator for this briefcase. I'm pleased to announce Dr. Potru will be introducing himself and will be giving the presentation today.
Hi, everybody. My name is Sudhir Potru. I'm a triple board certified anesthesiologist, pain specialist, and addictionologist at the Atlanta VA Medical Center and at Emory University here in Atlanta. And I will be very happy to present our patient case.
So before we begin, I want to let everyone know that the goal of this educational activity is to utilize the DSM-5 criteria to identify and diagnose opioid use disorder, which will be referred to as OUD, in patients prescribed opioids for acute and chronic pain. And hopefully throughout the presentation, you will learn how to develop strategies for engaging patients in treatment for opioid use disorder. We're going to be following a case. So Dr. Potru, would you like to tell us about the case of Jared?
Absolutely. So we have Jared, who's a 25-year-old male who is coming to our pain specialty practice today. Complaining of pain from a rollover accident with significant issues in his left leg. He was prescribed long-term opioid therapy by his PCP during that recovery process from the accident until he was abruptly tapered to discontinue about 6 months ago. Unfortunately, since then, PDMP is demonstrating a lot of opioid prescriptions from the emergency room dentists and a bunch of pain specialists after he was his opiates were discontinued by his primary care doctor. And it's important to note that these are single visits. So he's going to see pain specialists one time and maybe not really so much following up after that. So his medication list, specifically the opioids that he's on, is oxycodone extended release, 60 milligrams every 12 hours, and oxycodone IR, 10 milligrams every 4 to 6 hours. So if you're doing the math, this works out to 120 milligrams of extended release oxycodone, which is a time and a half is 180 morphine equivalents. And then the oxy IR, let's say it's 10 milligrams every 4 hours, is 60 milligrams. So that's 90 morphine equivalents. So we're looking at somewhere in the range of sort of 200 to 300 morphine equivalents here. He says he's been taking more or less this dose since his accident and has increased pain with attempts to lower the dose. Unfortunately, he's got a comminuted tib-fib fracture with a whole bunch of different surgeries and different things like this, is using nicotine as well as cannabis and alcohol products, and has a family history of an alcohol use disorder. So when we actually look at the important parts of this, what we see is he's relatively young, obviously. He had an accident a long time ago, which the traumas from that, to some extent, he should have had some recovery from. And unfortunately, he was abruptly tapered by his PCP. If we don't have the record of this, then, we kind of have to think about a few different things. We have to think about the possibility that, he may have been overusing his medication to some extent. We have to think about the possibility that he was, repeatedly calling, asking for early refills, different things like this. And this is kind of clearly demonstrated by what's going on as far as his PDMP use goes with these multiple prescriptions from, these multiple locations. We see that he has been on high dose opioids, very high morphine equivalents, and is complaining of pain with attempts to lower the dose, which, in theory means a few different things, right? That could be something like a tolerance sort of picture. That could be something like an opioid-induced hyperalgesia sort of picture. And of course, there's potential for opioid use disorder as well. We see that he has substance use from other places, cannabis and alcohol, and that specifically that family history of an alcohol use disorder is what kind of is particularly concerning in the context of him using very, very high dose opioid medications.
So I'll go ahead and ask an audience response question. So all of the following are DSM-5 criteria for diagnosing opioid use disorder, except. So think about the options here and pick a choice. The correct answer here is D. So all of the criteria listed are criteria for opioid use disorder, except frequently losing opioid prescriptions or medication. Now, certainly that could mean that the person has lost control or had compulsive use, but in and of itself, that behavior is not diagnostic of an opioid use disorder.
And now moving forward to the DSM-5 criteria, you can see that based on the number of criteria that you meet, you can establishes either a mild, a moderate, or a severe opioid use disorder. And what's particularly important to note is that this is different than just regular physiologic dependence, right? So addiction or a substance use disorder, by its very nature, demonstrates pathological use to the point where they're often continuing despite harmful consequences, messing up relationships with their families, screwing up relationships with doctors, losing their jobs, having other interpersonal issues, relationship problems, sometimes legal issues can be associated as well. And so these are important things to kind of look at and look into. And with the chronic pain patient in general, when we think about how to evaluate these patients in a clinical setting, we want to be very clear that we respect, we care about the patient, and that we're not stigmatizing or judging them for anything that they may have done in the past. And the problem is there are many healthcare practitioners out there who are continuing to do this. And the issue is that when you kind of make it clear, you telegraph exactly, your thoughts about maybe some of their previous behaviors, they don't trust you. And when they don't trust you, you can't build rapport with them. You can't really give them the help that it is they actually need. One of the ways that I've really found is helpful to sort of evaluate these patients and ask them intelligent questions about their pain and their opioid use disorder is to actually disguise your OUD evaluation as a pain evaluation. Asking things like, how do you use your pain medications? What benefits does it provide when you actually use it in certain ways? How frequently are you taking it? Have you ever taken more than you were supposed to? And are you running out early? What happens if you try to reduce the dose or cut back? Does anything else that you've tried work to help with your pain? All these types of questions will kind of give you a better sense of how frequently the patient's using opioids, whether or not they're overusing opioids, and kind of, where their sort of pain situation has also been in that context. We really want to be cautious and look very carefully for these OUD behaviors and indicators, interference with various work, family activities, preoccupation with getting medication, abandonment of various hobbies and stuff like this. And particularly, we want to focus a lot on what happens when they actually cut down on their medications, whether or not they're sustaining withdrawal symptoms, if they've built tolerance, all these other sorts of things. It's really, really critical for patients who have been in opioids, especially for a long time, usually high dose opioids for at least a couple of years. We really have to think strongly about opioid-induced hyperalgesia, which is a situation, if you're not familiar, where actually escalating doses of opioids ultimately serve to cause more pain. And the only really good treatment for OIH is ultimately a taper. There's some implication of the delta receptor involved in this. So there is some sense actually that buprenorphine as a different opioid as a delta antagonist may actually cause a little bit less of this sort of hyperalgesia kind of picture.
Dr. Pocher, I was wondering if you could talk a little bit about how you differentiate in someone who's prescribed opioids for the treatment of pain. Do you count those criteria towards an opioid use disorder in practice, thinking about the DSM-5 specifically?
Absolutely. So that's a great question, Dr. Weimer. Thank you. I really look at this in terms of it's challenging because we have a number of different things that could be going on with a patient who's prescribed opioids. There's the concept of actual true opioid use disorder with all the DSM-5 criteria that we've talked about. There's, physiological opioid dependence that develops essentially in the context of, opioid use, any kind of opioid use, whatever that is, as well as complex persistent opioid dependence, which is sort of a phenomenon sort of in between physiologic dependence and opioid use disorder. And it really presents some, challenge in terms of trying to figure out exactly what's what. This is why I think it's so important to ask the patient about their pain and get a sense of how their pain has actually been treated. And then you can look at the context of the opioid use and then sort of determine where it is you think they fall. And it's possible that, you may not be able to necessarily make this type of diagnosis immediately. This may take a few visits in terms of looking at how patients using an opioid medication on a continuing, ongoing basis to figure out exactly what it is the problem is, or whether or not they truly have an underlying opioid use disorder, or if this is something that we think is just possibly uncontrolled pain. I really, by the way, there are some people who talk about pseudo addiction, which is a term I really dislike. And I think, that's something that we need to kind of get out of our vocabulary to some extent as well. Does that answer your question, Dr. Weimer?
Yeah, I think it does. I think, like you said, it takes time to make this diagnosis. It's not going to necessarily be a slam dunk the first time you meet them. And I do think that a lot of individuals who may have pain and either opioid misuse or have developed an opioid use disorder do frequently attempt to seek care in multiple different settings. And the stigma associated with it is very, very high. So we want to be careful about just, saying, well, you have an opioid use disorder. I'm not going to treat you. So I think we have to be really careful about that, because we do want them to get good care, and we don't want them to be at risk to have an opioid overdose and things like that. I guess the one point I would just make is if they are prescribed opioids for long-term use and they are using those meds as indicated and as prescribed, we don't count those physiologic adaptations of withdrawal and tolerance towards them having an opioid use disorder. So just a relatively small but yet very important point, that just by having those physiologic adaptations, which we know occur with long-term use, that does not mean that your patient has an opioid use disorder. And being able to differentiate physical dependence versus an opioid use disorder is an important thing that I sometimes see clinicians get caught up on.
That's absolutely right, and critically important to note. A number of my colleagues in pain medicine will see this type of patient and see some sort of aberrant or irregular behavior and immediately discharge them from their practice, which doesn't really do anybody a whole lot of good. I mean, I guess as the physician, maybe you have a few less headaches as a result of it, but the reality is that, I mean, in a sense, you might be sort of abandoning that patient, and they may be kind of out there on the street, possibly in withdrawal, unable to get the care that they need for their pain or whatever it is, or even for their UD. And, you never know where things are going to happen once the patient leaves the healthcare system, right? You never know how things are going to go. And the consequences can potentially be catastrophic. It is really important to keep that in mind, that physiologic dependence and how that doesn't necessarily apply to those OUD criteria. I think that's a great point, and thank you for noting that. As we're looking at behaviors and sort of situations that the OUD versus prescription OUD versus the complex persistent dependence picture, we have a nice sort of table here that kind of shows us those different things. And there are things that are very clearly suggestive of prescription opioid use disorder with illegal activities, snorting and injecting, multiple episodes of a lost prescription, concurrent use of drugs, different things like this, deterioration in function, versus things that might seem a little bit more like a pain picture, right? Medication hoarding, requesting medications that have worked for them in the past, for that patient in the past, occasionally taking a few extra pills here and there, and not necessarily going to physical therapy, not necessarily getting the injections, not necessarily, wanting to do some of those things. But at the same time, you have to look at these patients in the totality of their presentation. It's not just these individual criteria are not necessarily going to make your diagnosis. This is going to take you some time, and this is going to be you looking at these patients sort of from a more holistic sort of perspective. If you are wondering a little bit more about complex persistent dependence, there is no ICD-10 code for this as of now, but this is something that was, I believe, first enunciated by Jane Ballantyne and Ajay Manhapra probably about 15 or so years ago, where they were looking at the distinction between a substance use disorder and dependence, and kind of sort of postulated this position in between, CPOD, where basically this condition starts and persists within the therapeutic context of pain treatment, as characterized by all these things that you see here: poor pain control, significant difficulty tolerating opioid tapers with declining function and aberrant behaviors, as well as medical and psychiatric instability. And so this is something that's important to consider. Incidentally, this is something, CPOD, that lends itself well to buprenorphine treatment, because the buprenorphine, in addition to taking care of some of their withdrawal symptoms, oftentimes smooths out some of their psychiatric instability, lifts their mood because of the kappa antagonism of buprenorphine, and sometimes is a little bit more helpful or beneficial for some of these patients. Going back to Jared, he tells us that previous physical therapy trials lasted about a month and a half, but weren't particularly helpful, so he ended up stopping. He's tried multiple adjuvant medications that really didn't help him, so he didn't really get or see a reason to continue doing that. We see that he's really going to a number of different physicians, but always goes back to the PCP for management, says everybody just tries to switch my oxy since it's a hassle to prescribe and they don't care if I end up in pain. So when we're looking at these, when we're looking at the criteria that we're looking to meet, clearly he's going to a number of different specialists. He's going out of his way to get these types of medications and things like this, and just goes to them a couple of times, a lot of these pain doctors, and goes back to his PCP after this. He's very insistent and persistent, it looks like, with regarding to these medications, to the point where he may actually be damaging some of the relationships he has with some of these clinicians, and that's why he's only seeing them 1 or 2 times. On exam here, we have him grimacing frequently during the examination, of course, pain with flexion extension of the left foot, which maybe we would expect to some extent. Intense pain with any palpation or manipulation, the entire extremity is painful. So this is a real challenge from a diagnostic standpoint. When he says his entire extremity is painful, we have to really sort of think about the possibility of complex regional pain syndrome, as well as an opioid-induced hyperalgesia picture, because in theory, both of them are possible in somebody with a significant traumatic history, as well as multiple surgeries, fasciotomies, things like this. There's significant propensity for nerve damage here, and these are all things that we have to note. It's helpful that he doesn't have any swelling, redness, edema, the more sort of trophic characteristics that we would look at from a CRPS kind of picture, which is kind of leading us a little bit more maybe toward the opioid side of things in this context. As far as our screening and our history, we're looking at all of this to see that he is reporting significantly increased intolerable pain with any tapering, anxiety about securing his next dose, is saving his medication, hoarding it, essentially using that when he is not able to actually obtain these medications, runs out of oxy-IR early every single month, lost prescriptions, early refills, denies any overdoses, and basically even though he denies an overdose, that ED visit demonstrating that they were unable to arouse him from sedation is obviously really important and clearly demonstrates that that's probably what happened. And so when we think about in that context, exactly, how likely these scenarios are, this is something that it may not be this extreme upon an initial presentation, but I have definitely seen patients like this, and I'm confident that Dr. Weimer has as well. Patients who have this constellation of symptoms of pain and substance use, where it becomes difficult necessarily to differentiate exactly what's what. But when we think about what's really driving his behavior, when you think about what he's looking for every single time, it really is a strong focus on the medication, right? He's saying he's having pain when we try to reduce it, anxiety to get the next dose, he's running out early every single month, there's history of overdose. This is where we really have to be cognizant and careful in caring for him to make sure that we're not going to create a bigger problem.
Yeah. I agree. And, I think he is young. And what I see in a lot of the younger patients that I treat is that we might see them in their 20s, but things with their substance use may have started way long in their adolescence. So I think as you build rapport with this person and as he starts to trust you and you start to get more information about how he's really doing, you might uncover that there were earlier signs of substance use that, again, don't mean that he absolutely has an opioid use disorder at this time, but could mean that he's at higher risk. So, he's somebody who I would probably talk to and say, how are things going? Like, tell me about your life. Are you functional? Do you have a job? Are you able to do, the things you want to do at age 26? And as you mentioned before, buprenorphine or some other treatment might be much safer for him in the long run, and provide better pain management for him. All right, so let's have another question here. Which of the following is an evidence-based treatment option for opioid use disorder? So you have 5 different options here. Think about the right choice. So the correct answer here is B, medication for opioid use disorder without psychosocial therapy. Now, it is true that typically we do think that providing medication for opioid use disorder with psychosocial therapy is important, but there are studies showing that even medication management done by a clinician in an office can be highly effective. And certainly for some people, particularly in primary care or in a pain practice, can be really the first start for them to getting well. And then as they get well, they feel better, then they may decide that they want to go on to get additional psychosocial treatment. But it doesn't have to be a mandate of medication for opioid use disorder.
Absolutely. And I think it's really important also to remember that, as Dr. Weimer points out, it's really helpful as a pain clinician sometimes to have, my addiction, although I'm a certified addictionologist and I treat patients with addiction, to have resources around you that you can sort of bridge patients with a buprenorphine prescription or something to get them into that sort of ancillary psychosocial treatment availability, to make sure that they're getting truly comprehensive treatment for the substance use disorder as opposed to just medications. Although it is really important to note that the number needed to treat with something like buprenorphine is 3. Literally, I mean, to save somebody's life, you literally just have to treat 3 patients. And so it's something that even if you don't necessarily have available psychosocial resources, even just initiating them with buprenorphine therapy may be something that saves their lives in the context of them not having anything else, withdrawing in a place, unable to access treatment. These are all things that we have to consider. And so now looking a little bit forward here and moving into the neurobiology of opioid use disorder, we know that OUD is a chronic disease with significant potential for recurrence and recovery. There's a problematic cycle that we have with a sort of a binge intoxication phenomenon, withdrawal that results in obviously physical symptoms as well as a negative affect, and then a preoccupation or anticipation that results in further use. There are significant changes in the brain in a number of different places that happen, but unfortunately that initial opioid use can be driven primarily by that reward pathway, which can result from initial use. Then we later on have discomfort avoidance or avoidance of withdrawal, essentially trying to avoid that negative affect, that withdrawal sensation, in order to ensure that they're going to be normal and not challenged with all the physical things that happen and emotional things that happen with withdrawal. The unfortunate problem is that there are significant chronic changes that happen with rewiring of your brain, and especially reward centers, the prefrontal and frontal cortices, as well as nucleus accumbens. We see significant changes that take typically years actually to improve and go away. There's a really cool study where Nora Volkow from NIDA showed patients who had used cocaine remotely several decades even before, and she showed them pictures of cocaine and their nucleus accumbens, their reward center, still lit up like Christmas trees, demonstrating that that brain neurocircuitry was still reactivated in that context. As I said, there are multiple disruptions that have taken place in the brain, including the basal ganglia, the amygdala, the prefrontal and frontal cortices. We get substance-seeking triggers, especially depending on where that is. That might be a friend of a patient who's used an opioid or drinks alcohol, something like this. That might be a certain place where they often use these medications or often, utilize illicit substances. And you get significant reduction in sensitivity of the pleasure or reward systems, right? The normal life-sustaining things that we do, eating, drinking, defecating, urinating, orgasming, right? The things that cause dopamine release in our brains. Unfortunately, the relative scale of dopamine that's released compared to some of the illicit substances is substantially changed. And that's why we get a number of these problems. But I think it's really important to think about how to actually talk to OUD patients about treatment, right? It's really, really critical to make sure that you're looking at how you're talking to these folks. And one of the ways that I've found to do this, because I was raised in an environment, in an atmosphere, I was taught that addicts were bad people who did bad things, right? That's what I was taught. I was from a privileged sort of situation. And so I started thinking about relatives and loved ones and friends that I had who had had problems with substance abuse, whether those were alcohol, opioids, other different things. And I started trying to imagine those people sitting in a pain clinic and saying, how would I want that person to be treated? How would I want my family member who had an issue with alcohol to be treated if they were actually going to go and get their chronic pain, managed by a pain specialist or a PCP? And I think that will kind of help you if you don't necessarily have a ton of experience with this, to generate some empathy. That will actually allow you to show empathy kind of on your face if you visualize somebody else who's actually there with you that you care about. And I think that will, kind of empower those patients to be a little bit more honest with you and kind of explain exactly what their situation is and how it is you can actually help and meet them. So non-judgmental, empathetic support, obviously very, very important. And asking open-ended questions in this context is particularly critical. Helping them address their triggers using motivational interviewing, where you basically get them to talk about the substance use issues that they've had and how it's affected their own lives, to make them verbalize it will actually, push them along that cycle and desire to change. It's really, really so important to not assume that patients understand exactly, the consequences of their use, right? They very frequently don't. With opioids, it may be a different scenario. With the opioid epidemic, people realize that, folks are dying every single day, but they may not realize that, there are long-term consequences to using opioids, even if you aren't injecting them, even if you aren't overdosing. There are significant long-term consequences to using these things. And above all, and that's why we have it here in red, do not discharge these patients without a follow-up plan, unless there might be really kind of individual unique situations where the patient just walks out and you can't get them back. I mean, that happens, but the realistic truth is that if you leave these patients without some sort of follow-up plan, the likelihood that something catastrophic is going to happen to them is unfortunately extremely high. And we have to be very, very cautious in terms of how we're handling these very vulnerable and complex people. So in terms of our treatments for opioid use disorder, we have 3 FDA-approved medications. By the way, if you didn't know, there are actually only 3 substance use disorders with FDA-approved medications. That's alcohol, opioids, and tobacco. And we're fortunate with OUD to actually have some really helpful things. Methadone is a full opioid agonist with a very long half-life. Because of the doses required, which is typically 70 milligrams and often much higher than that, you can only prescribe methadone for an opioid use disorder through a federally regulated opioid treatment program, which some of you may know better as a methadone clinic. Buprenorphine is a partial agonist, meaning that there's a ceiling effect on what it actually does from an opioid standpoint. The really nice thing about it, it's generally a safer opioid than most of the full agonists that are out there, as well as the different illicit opioids that are out there. It's really nice because it's safe enough to be prescribed in an office-based setting, as well as in a more dedicated sort of opioid treatment program. We have to be really careful with how we use it because of its activity, its partial agonism. If somebody has a full agonist in their system and is not demonstrating any signs of withdrawal at the time when it's given, you can potentially precipitate withdrawal with its use. I found a lot of ways around this. I've initiated buprenorphine therapy utilizing a Butrans patch or Belbuca buccal formulation before I actually escalate them to a milligram dose buprenorphine product. If you didn't know, by the way, Butrans and Belbuca are microgram doses and are not indicated for the treatment of opioid use disorder because they don't block enough receptors, they don't occupy enough receptors to actually block the cravings and withdrawal symptoms associated with OUD. That said, I have used milligram dose buprenorphine, which is your Suboxone, Subutex, those types of products for pain. And you don't actually need the so-called X waiver to do that if you don't have it. But you can use these things, in different ways depending on the situation. The last one of these is naltrexone, which is an opioid antagonist. It's really, really, really challenging to initiate sometimes, but is very, very effective and very helpful. Naltrexone is actually indicated for both alcohol and opioid use disorder, but it's only FDA approved. The long-acting injection is what's approved for opioid use disorder. Importantly, patients have to be opioid-free for about 7 to 10 days in order to ensure that you're not going to precipitate withdrawal symptoms. So that can be a little bit of a challenge, in patients who are using opioids on a regular basis. It's also particularly critical, and we don't mention it on the slide, but this is actually really important, to make sure that we're managing these patients' pain, at least to the extent possible, because uncontrolled pain is a significant risk factor for relapse. And it's really, really important to keep that in mind, because if you have patients who have uncontrolled pain, even if you are controlling their cravings and their withdrawal symptoms to some extent, you may still be driving them towards something that may give them some analgesia. And it's really important to keep that sort of in the context of the actual treatment.
And I would just add that it's now easier than ever for all people with a DEA license to be able to prescribe buprenorphine by going to the SAMHSA website and putting in your notice of intent. There's no required training any longer in order to treat 30 patients or fewer patients. And as Dr. Potru was saying, if you can save one person's life by treating 3, then there's your chance right there. And if you can initiate the treatment while they're in your office, then we think that that's also the most effective to getting them engaged in care. So If you don't already have your waiver, it would really encourage you to go to the SAMHSA website. It takes 5 minutes, like literally 5 minutes, and you really could have a huge impact on your patients. So thank you so much for that really great talk, Dr. Potru, for all of your insights. I think we learned a lot today. So pulling it all together, thinking about our SMART goals and how we might put some of these principles that we learned into practice. After today, we hope that participants will monitor for risks of opioid use disorder in the patients they're treating who are receiving long-term opioid therapy. Hopefully you've been able to get some insight into how to differentiate the origins and drivers of opioid-induced hyperalgesia versus opioid use disorder versus alternative opioid-related conditions, opioid misuse, physical tolerance, withdrawal, physical dependence we talked about. And then finally, use shared decision-making to encourage patients with opioid use disorder to engage in psychosocial and medication treatment for opioid use disorder, which really is the gold standard and which is currently underutilized in our country. And we need to make sure that our patients are receiving this vitally important medication. So we have multiple other cases in the CME briefcase that we hope that you will engage with. You can see them listed here. And these activities, as well as many other educational resources for clinicians and patients, can be found online at the CME Outfitters opioid and virtual education hubs. To receive credit, please go to and complete the post-test and evaluation online, and then you will be able to obtain your certificate. Thank you so much for your attention.
Thank you, guys.